Welcome back. After we have known and mastered the basic concepts of ECG, now we will go through the very important part and the magical part in our course, which are the secret codes and code solvers in dealing with ECG. Code solvers of ECG. The first main and very important concept before dealing with the ECG paper is that you must interpret ECG in the clinical context. I mean, never to comment or given your opinion about an ECG except after knowing the clinical scenario of this ECG, for which patient, what is his complaint, what are his risk factors, etc. Because, for example, if the ECG for a pregnant lady in her last trimester, with the gravid uterus pushing the heart upward, shifting and changing its axis, it will produce changes in the ECG. You can misinterpret these changes as the patient has a myocardial infarction, especially inferior myocardial infarction. And this is wrong. If you know that this ECG is for a pregnant lady, then you will know and mention that these changes are normal physiological. If you see an ECG for a young boy 10 years or below 70 years, you will see changes that may give you impression that this patient has a right ventricular hypertrophy and dilatation. But if you know that this ECG is for a young boy, you will know that this is the persistent juvenile ECG pattern. So never comment on an ECG except in a clinical context. So what are our 12 codes for the 12 lead ECG? Concentrate with me. The first code is the connection and calibration, and the second one is the artifact. In these two codes, you make sure that you have taken the image with the best standard quality that can make you able to interpret and analyze it accurately. So the first code is connection and calibration, and the second one is presence of artifacts. Then you can measure the rate and can you see the rhythm and define the axis of the heart. In the coming seven codes, you will analyze the different parts of the image: the B wave, the BR interval, the QRS, the ST segment, the T wave, and the whole QT interval, and finally the U wave. So the last seven codes are the parts of the segment, and we analyze them in a precise way. And the first seven codes and the first five codes are connection and calibrations and artifact, then rate and rhythm, and finally the axis. In the coming short videos, we will discuss each code in detail and know its clinical importance. So in dealing with an ECG paper, you should go through these codes step by step. Never jump to see the QRS or jump to see the T wave, except going through these codes in this special order. So let's let's start with the first code. I hope you have enjoyed our session and see you in the next video. Welcome back. In the previous video, we have known what are the 12 codes for the 12 lead ECG. In this video, we will start with the first code, which is connection and calibration. What is meant by connection? Connection means that you are putting your 10 electrodes. I mean that you have put your cameras in their exact position, never changed the position of the cameras. Because if you change the position of the cameras, you will get an abnormal images. You will get an inverted images. So how can we know that? Especially, sorry for the interruption, especially if the ECG is done by a nurse or a coworker, not by you, by yourself. So how can from ECG we know that it is properly connected? And the key here is to look at the AVR. Normally, if the ECG is properly connected, you'll find the AVR is totally negative with a negative B wave, negative QRS complex, and the negative T wave. If the AVR is not negative, if it is positive, then you have changed the position of the electrodes. You have changed the position of the cameras. So the first thing is that your eyes look at in dealing with an ECG paper after knowing the clinical context of the ECG is to look at AVR. If it is negative, then it is properly connected. If it is positive, then this ECG is wrongly connected, or there is another explanation. If you ensure that the position of electrodes and you find that the electrode position is exact, is right, is correct, and you find that AVR is positive, not negative, then you think that the heart position is the opposite. I mean that this patient has dextrocardia. Yes, right. Okay, so if you look at the ECG, the AVR, and you find that it is negative, then it is properly connected. Then move to the calibration. Is this ECG is done on the standard calibration or not? And here calibration includes two parts: the amplitude or the voltage and the speed of ECG recording. The standard calibration is that you image the ECG or you image your video at the standard speed of 25 millimeter per second, not less than 25 or more than 25. So the standard speed on the x-axis is 25 millimeter per second. And the standard calibration or zoom is 1 millivolt. And 1 millivolt equals 2 large squares. And here in the ECG, you'll find this mark. He is marking 2 squares. He tells you that this ECG is recorded on a calibration of 1 millivolt, which is the standard calibration. So in dealing with the ECG paper, you should first look at AVR, ensure that it is negative, so it is properly connected, and look at the calibration, look at the speed, and ensure that the speed is 25 millimeter per second, and that the calibration, the voltage or the caliber is 1 millivolt, and this mark includes 2 squares. Then we will see in the next slides some different changes in the connection and calibration. Look at this. This is the standard calibration with 1 millivolt, 2 squares. So this is the image of or the shape of the ECG, P, QRS, and T wave. If you look at this image is taken at a calibration of 1 millivolt, only 1 millivolt. So the voltage of the ECG is lowered. If you don't take care that this is a half calibration, then you can make a diagnosis of low voltage ECG, and you your thinking may go through the presence of a pericardial effusion, a barrier or hypothermia, etc. And if you look at this is taken at a double calibration. This makes the voltage of the QR is very huge. That it gives you a false impression that this patient has a hypertrophy. So if you don't take care that this ECG is taken at a double calibration, you can misdiagnose the patient as having a hypertrophy in his heart. So this is the magic of taking care of your voltage or of your connection and calibration. If you look at this, the first, let's apply. The first thing that your eye will look for is the AVR. Oh my God, it's positive. So it's a wrong connection. So I cannot interpret anything in this ECG. Please repeat the ECG with proper connection and give it to me. If you look at lead 1 and AVL, you will find them negative. And this may give you a false impression that this patient has a neglected lateral MI. If you remember that one an AVL images the lateral wall. So this picture with inverted T and Qs will give you a false impression that this patient has an old MI, which is false diagnosis because this image is wrong because this ECG is wrongly connected. So ask to repeat and never interpret this ECG. Okay, let's apply. Look at this ECG. Look at AVR, it is negative. So it's properly connected. Look at the calibration. Oh my God, it is 4 squares. It's a double calibration. Give me a false impression of high voltage. So this ECG is recorded on a double calibration. I cannot interpret this ECG. Please repeat ECG with the standard calibration. Oh my God. Regarding the speed, if you look at this is the normal with a speed of 25 millimeter per second, which is the standard speed. So gives me this image. I can calculate the rate, which is about 70 beat per minute, as we'll know in the next section. But look at this. If you take this the same ECG, but with a speed of 50 millimeter per second, you increase the speed of the paper. The heart is beating constantly, but the paper runs rapidly. So the space between 2 QRS will be great. So this gives you a false impression that the patient is bradycardic, has a slow heart rate, which is false. Actually, if you make the speed the standard speed, which is 25 millimeter per second, you'll give you the exact image. So if you notice, there is a inverse relation between the speed and the impression of heart rate. If you increase the speed, it gives you a false impression of bradycardia. If you decrease the speed, make it like 12.5, it will gives you a false impression of tachycardia. So make sure that the speed is the standard speed, which is 25 millimeter per second. As sometimes the doctor not take care of the speed and refer for us this patient with this better, as the patient has a severe bradycardia and need to put a pacemaker in his heart, and actually the patient has a normal heartbeat. And this is a very big mistake and shame for you as a doctor to make this foolish mistake. Okay, so you have to focus firstly on the connection and calibration, and make sure that your ECG is done with the proper connection and standard calibration. In the next video, we'll talk about the artifact and know what is it and how can it affect on the ECG. Hope to see you and goodbye. Welcome back. After making sure that your ECG has passed the first code, which is connection and calibration, you will look for the second code, which is artifact. What is meant by an artifact? Artifact means distortion of electrical activity recording of the heart by non-cardiac causes. Like what? It may be due to loose electrodes. You don't put an accurate amount of gel on the ECG, or your electrodes are not properly connected and attached to the body of the patient. It may be due to a broken cables or wires. It may be the patient himself. The patient has a muscle tremors like Parkinsonism. The patient is disturbed conscious level and is moving and you cannot control his movement. If the patient is a child and he is moving always, or there is an electrical current near the patient, make electricity interfering with the quality of the ECG, or you are doing chest compressions, CPR, while you are recording the ECG. All these non-cardiac causes can cause artifacts in the image. And artifacts in ECG is equal to pixels or an image poor pixels, which makes the image hazy and you cannot see the person well. Exactly here. If you look at the ECG, this is a good one, and the black dots here is the artifact. Here you cannot see accurately the T wave, you cannot see any P wave, and you cannot comment on this ECG. So you must make sure that your ECG is free from artifacts. Let's see some examples of artifacts. If you look at these are artifacts of a patient that has a muscle tremors, as I said, a Parkinsonism, and here this part of ECG you cannot comment on it at all. Sometimes you can overcome this by making a patient consciously to control his tremors, or even we can give him a sedation or a general anesthesia. If you look at this patient is moving, so the baseline of the ECG is wandering, come up and down, and here you can give a false impression of ST segment depression. Here ST segment depression, which is falsely, and here a false impression of ST segment elevation. And anyway, if there is a presence of an artifact, you cannot comment on the ECG. Also here, this patient is hypothermic and is shivering. So the shivering artifact make ECG like this. And this can be misinterpreted as the patient has a fibrillatory waves, and you can misdiagnose that the patient has an atrial flutter or atrial fibrillation. And actually it's just an shivering, a shivering artifact. So make sure before commenting on the ECG that there are no artifacts. So finally, after passing through the first two codes of our 12 codes, you make sure that your ECG is properly connected with standard calibration and no artifact. If it is like this, then you can go through the next code, which is calculating the rate, and make sure that this patient has a normal heart rate, which is from 60 to 100 beat per minute, or the patient is tachycardic with a rate above 100 beat per minute, or if the patient is bradycardic with heart rate below 60 beat per minute. And the method of how can we calculate the heart rate will be discussed in the next video. Thank you very much and see you in the next lecture. Welcome back. After we have got through the first two codes of ECG secret codes, which are connection and calibration and artifacts, now we will start with the third code, which is calculating the heart rate of the patient from ECG. And I'll tell you honestly that it will be a very easy one because we only have two rules to calculate the heart rate. If the heart rate is regular, I mean the heart is beating regularly with irregular spaces between all QRS complexes, then we apply the rule of 300. And if the heart is beating regularly with regular spaces or distances between each QRS and the other one, then we apply the rule of 6 seconds. Let's go through these rules. I will go to the whiteboard to explain this for you, then we will come back to our presentation. If you remember, this is the ECG paper, and the heart is beating like this. Each contraction is represented by a QRS. Each contraction is represented by a QRS. Each contraction is represented by a QRS. So if I want to calculate the heart rate, which is meant by heart rate means number of heartbeats per minute. The number of heartbeats per minute. Number of beats per minute. How many times the heart contracted in a minute? Okay. For beating is represented by a QRS. So I have to calculate how many or the number of QRS complexes in a minute. And from the ECG paper lecture, you remember we have said that a minute equals how many large squares? If you remember, we have said that every 5 squares is a second, equal 1 second. So a minute, which is 60 seconds, equal 5 multiplied by 60, which equals 300 large squares. So to calculate the heart rate, we have to measure the number of QRS complexes in 300 large squares, which needs a huge length of an ECG paper, and this is not practical from the practical point of view. So to overcome this, it's an easy one. If it is regular, I mean the space or distance between each QRS and the other one is constant, then simply I can calculate how many large squares between these two RS complexes and divide 300 over this number. It will tell me the number of QRS complexes in this 300 squares, I mean in the minute. For example, if there are 3 large squares between two QRS complexes, then 300 over 3, it will tell me that there is a 100 QRS complex in the 300 squares, I mean in the minute. And 100 QRS in the minute means 100 beat per minute means the heart rate. So if it is regular, I mean the space between each QRS complex and the other is constant, then it's very easy one. Apply the rule of 300. Measure the number of large squares between two QRS complexes and divide 300 over it, you will get simply the heart rate. I hope you got it. Okay. Then what if the most difficult one? I will bring another flip book to explain. I hope you are getting the concept with me. These forms are difficult, but I hope my explanation make it more easier for you. Imagine with me that the patient has irregular heartbeats with the space or distance between each QRS complex and the other one. So the space or the distance between each QRS complex and the other one is unequal. So here we cannot apply the rule of 300, and we have to measure the number of QRS complexes in the 300 square. And this is also not practical. So how can we overcome over this? We can take only 6 seconds and calculate the number of QRS complexes in it and multiply it by 10 to form a 60 second, which is 1 minute. Then it will give me the heart rate. So here I mark a 6 seconds. 6 seconds equals how many large squares? We have said that a second equals 5 large square. So 6 seconds, 5 by 6 equals 30 large square. So I calculate a 30 large square, define them, and number the QRS complexes in this 30 squares, multiply them by 10, then I get the heart rate. This is called the rule of 6. And I think it is a very easy rule. If we can imagine that this area is the 30 square, which is the 6 second, then I can measure the number of QRS, which is 1, 2, 3, 4, and 5. There is 5 QRSs in this 6 second. Then 5 by 10 equals 50. So the heart rate is 50 beat per minute. 50 beat per minute. This is the rule of 6. Let's go back to our presentation. So if the QRS complexes are regular, you apply the rule of 300. If it is irregular, you apply the rule of 6 seconds. So if it is regular, the rule of 300 takes the number of big boxes between neighboring QRS complexes and divides this into 300. This will result approximately to the rate. Let's apply. If you look at this, here the space or the distance between QRS and the other is equal. So I can number how many large squares? 1, 2, 3, 4, 5, and 6. So there are 6 squares between QRS and the other. So 300 over 6, it will give me the rate of 50 beat per minute. Let's apply it again. If you look at this, the space here is equal between each QRS and the other. How many squares? 1, 2, 3, and 4. About nearly 4 squares. So 300. Sorry, this is a mistaked one. So 300 over 4, it will give me the heart rate of about 70 beat per minute. If you look at this, here the space between each QRS and the other is equal, and it's about 1 and point square. So 300 over 1.5, it will give me the rate of 200 beat per minute, which is tachycardic. So to make it easier, if it is one large square, then the heart rate is 300 over 1 is 300. If it is 2, 300 over 2 will be 150 beat per minute. If it is 3, it is 100 beat per minute. If it is 4, it is 75 beat per minute. If it is 5, 300 over 5, it is 60 beat per minute. And if it is 6, 300 over 6, it is 50 beat per minute. Okay, if it is irregular rhythm, then you'll apply the rule of 6. You can simply count the number of beats present on an ECG in 6 seconds, which is 30 large squares, and multiply them by 10 to get the number of heartbeats in the 60 seconds, which is in the minute, which equals the heart rate. Let's apply. Yes, here the space or the distance between each QRS and the other is unequal. So I calculate a 6 second, which are the 30 large squares. If you number with me, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, and another 15. These are 30 large squares. How many QRS? 1, 2, 3, 4, 5, 6, 7, and 8. So there are 8 QRS, 8 by 10. So the heart rate is 80 beat per minute. Okay, I hope you got it and know how can we measure the heart rate. In the next lecture, we will speak about the most challenging part, which is the heart rhythm. See you in the next lecture.